Well, welcome everyone. Welcome to Anterior segment, Grand Rounds, Corneas, Cases, and Complexities. Joe's going to be our speaker tonight, and I think most of you know Joe, but he's definitely worth having an introduction here for those who may be their first time. Joe, I'm going to be using your old bio. Like I said, I can't find a new one. So, Joe served as a professor of optometry at Nova, Southeastern University College of Optometry for 28 years, and I think 2 days to be exact. Here he was the chief of the Advanced Care Service, director of Glaucoma Service, chair of the Department of Optometric Services. Joe is also a member of the Optometric Glaucoma Society and the Optometric Retinal Society. He also he's the chair of the Neuro-Ophthalmic Disorders in Optometry for the American Academy of Optometry. Joe is a gifted writer. He has hundreds of published articles, lead author of the annual Handbook of Ocular Disease Management. This is by Review of Optometry. I think most of you know Joe is a well-known national and international lecturer. Joe is currently at Center for Sight in Sarasota, Florida. So with that said, please give my friend, my partner, a great educator here, a big virtual round of applause.
Well, thank you, Greg. I think we're going to have hopefully a good time. I'm going to lead this discussion. I'm going to ask Greg to give his input, his thoughts, his opinions, and to fill in whatever I seem to forget sometimes. So anterior segment grand rounds. These are my disclosures. I have no financial interest in a product, disease, or instrumentation. All my relevant relationships have all been mitigated with Greg. I'm also co-owner of Optometric Education Consultants. Greg, I did put your disclosures in here as well because I know you'll be participating.
Great. Really, the biggest thing there is I'll just hit the last bullet point. The content and format of this course is presented without commercial bias and doesn't claim any superiority over any commercial products or services, and all of the above have been mitigated through COPA.
Excellent. All right. Well, first is a case. We're going to do this in a case-based presentation. He was a 21-year-old plumber who calls in, and this was a phone triage. He had hit himself. He was working. I think what had happened was he was using the wrong tool for the job, and he was banging on something with a screwdriver, and he recoiled and quote unquote hit himself with the blunt end of the screwdriver. And he said that there's a lot of fluid running down his cheek. He took some Tylenol for the pain, and it mitigated his pain really pretty well. And he said, there's a loose flap of skin that he's been trying to get off, but he really hasn't been able to do that. And I don't know, Greg, you ever been in that situation where you just got that really bad feeling? You don't know why, but you just got a bad feeling. This is one of those cases where I just kind of had a bad feeling when I heard about this. And I wasn't on the floor that afternoon, but I decided to wander back over and just kind of check things out. But that's going to bring me to polling question number 1, if you don't mind that. In triage in this case, what's the most likely diagnosis you're expecting? He's got a uveitis, an abrasion, a conjunctival laceration, a corneal laceration, or, I'm not sure. That's why I'm here. And I'll just give you back what I got in triage over the phone. And I think when I say triage over the phone, I just happen to be in the room, overhearing a resident talking, triaging this. The first thing, I had a kind of bad feeling.
The handout, Joe, I just put into the chat room for you guys that need it. It's in the chat room. I like the idea of loose flap of skin. We see these quite a bit, and I know you're down in Florida, Joe, but you grew up in New York, so you'll kind of get where I'm going. I live in a rural area, and we do a lot of our own work out here, and people are constantly in that April, May, taking off the snow tires, putting on the regular tires or the summer tires or the all year tires. And things get salted and corroded, and they're trying to pry stuff off, brake pads and covers and tires and screwdrivers and stuff end up in eyeballs. So we see that quite a bit.
So there are a lot of things, and really anything here is pretty reasonable. All right, well, this is what he looked like. Oh, did we share the results?
I have sharing because I have it
Okay.
says stop sharing.
All right. So people look into your uveitis and abrasion, laceration of the conj or cornea. I'm not sure that's why I'm here. These are all very good possibilities. And until the patient comes in, you just don't know. And this is what he looks like. And what we can see here, obviously, is he has got a bit of correctopia. And he has this linear defect here. We can see that there's a little bit of blood here at the limbus. And I think it's pretty clear as to what we might be dealing with here. We look at him in another view. He's got quite a bit of inflammation. There is actually some blood in the eye there. We have this really pretty significant linear issue. The anterior chamber is really pretty flat, and that actually brings me already to the polling question number 2, Greg, if you don't mind launching that. So what's the most likely diagnosis now we see him in the office? Is it simple uveitis, an abrasion, a laceration of the conjunctiva? Is it a corneal laceration, or I'm not really sure? That's why I'm here.
Maybe go back to the picture, Joe, while they're
Good idea.
Correctopia, is that a misshapen pupil?
Yes. And this is actually a fairly well-recognized photograph. I've actually seen this show up in other people's presentations. People I don't even know, but this is actually definitely my photograph. We're down to about 81% response. And Greg, if you want to, should we end and share?
Yeah, leave it there because I have a question once you go over this, and I'll share it.
Okay.
There are
So
your
by
answers.
and large, everybody's saying corneal laceration. We got a conjunctival laceration. Certainly anterior uveitis is going to be there as well. Craig, you had a question?
Yeah, up there at 12 o'clock on that photo, there's those 3 little bubbles. Is that in the anterior chamber?
Yes.
Okay.
Now we're dealing with a corneal laceration. We have an open globe. We have an open cornea. Now, when in doubt, the quintessential test that we want to do would be the Seidel's test, where you paint the suspected area to see if aqueous will percolate out or percolate through. And this is a fellow who was lacrimating a little bit too heavily to do a good Seidel's test on. But I can tell you, and this is my own personal opinion, I don't have any literature to back it up. But when you see bubbles in the anterior chamber, to me, that's not a very good sign of corneal patency. So he probably was actually hammering with the blunt end of the screwdriver on the pipe he was working in. He actually recoiled back and hit himself with a sharp end. And the fluid running down his cheek obviously was his aqueous, and the loose flap of tissue that he was trying to remove was his cornea. He's actually trying to remove this or pull this off. Now, a consideration, he's a plumber, you can imagine where his hands have been on the job. So it's not a pleasant situation here. So we have a patient who's got a full thickness, pretty extensive corneal laceration. So these patients will have really quite a lot of pain and probably some decreased vision because the whole refractive surface is just not working properly. Obviously it's going to be deeper than an abrasion. They can be smaller, it can be linear. The Seidel's test is actually fairly important. You may see a hyphema. There could be an anterior chamber reaction. Relatively, the anterior chamber could be shallow or flattened. Air bubbles can be in the anterior chamber. Now, keep in mind positive pressure. You don't have much pressure in that anterior chamber there's more pressure in the posterior chamber. So what's happening is it's actually going to prolapse the iris forward, and it's trying to plug that wound. If you try to manipulate a person like this too much, you can extrude the uveal tissue through that wound. And that's, that's worse because that's something that you contributed to. Don't worry about pressures on these patients. The pressure is going to be low. I mean, if it spikes up to 0, I would actually be shocked. So tonometry is nothing that is necessary here. And of course, doing a Seidel's test, you want to paint an area with fluorescein to see if you actually see that that dark pool of aqueous percolating out.
Joe, go back to that, because I remember the first few times whenever I was trying to do a Seidel's, and I think the word that we always say, but until we try and put it into clinical practice, is paint. And I remember the first time, this almost looks like a cataract type of surgery here. Maybe that's leaking. And obviously, I don't think it's the patient that you're just showing us.
No, it's not.
But the key is, the first time I was looking for a Seidel, like I put the sodium fluorescein in the eye, walked away, sat down, pulled the microscope over and said, okay, let me see if I see a Seidel's in there. And that's not really how you see it. Like what you want to be doing here is this person is looking down. You can see that wound leak is, up around the limbus there, limbal area. Maybe it's a cataract surgery. Maybe it's another type of foreign body or, penetrating. But what you want to do is you want to get behind the microscope. And as Joe's saying, paint that fluorescein. And then because if it's a fast flow leak, it's going to push it away. So you can see how that's pushing it away there. And by the time you sit back down, walk over, pull the microscope over, turn on the cobalt blue, rat and filter, do all that, it's gone. You're going to miss the Seidel's. So you literally want to be back behind that microscope, like Joe is saying, painting and watching, because it will flow pretty fast.
And sometimes you actually have to put a little pressure on the cornea, because in a lesion like I'm showing you here, this laceration, that's really pretty obvious. But a perforation, something going in or in and out, like a dart or something going through a high-speed foreign body, these are things they can actually self-seal. And you may not realize the cornea has been breached until you put a little bit of pressure. And I can think of a situation, one of my former residents, who I don't think is on the webinar tonight. By the way, hello to all my former students out there. I see a bunch of familiar names. He had a patient with a perforating injury that more or less self-sealed. And he referred out to a corneal specialist, and the corneal specialist contacted him and said very nicely, thank you, but it really just a corneal abrasion. Well, what she didn't know was he actually filmed the Seidel's test and put it on YouTube. He sent her the link, and then she called back and said, oh, thank you, you're right, it was a perforation. We have to address it as such. Now, anytime that you have a high-speed injury, you've got to consider something has been perforated. It doesn't have to be the cornea. It could be the scleral tissue. Case in point, I was asked to defend 2 optometrists who allegedly had misdiagnosed a person with a weed whacker abrasion. This fellow was working as weed whacker, and he started it up in his garage and spit something off that ricocheted back into his eye, and they treated him for a corneal abrasion. And when he came back 2 days later, he was documented as having a shallow anterior chamber, a pressure less than 5, and a hypopia. And really what it was not a corneal abrasion, but a self-sealing corneal perforation, which there was an intraocular foreign body, which led to an endophthalmitis, which led to multiple retinal attachments, and the fellow lost his eye. So pearls to remember: perforations can self-seal. I mean, a big knife cut across the cornea or a screwdriver cut is not going to do that. But perforations can self-seal. That's why maybe a little pressure on there, see if it starts to leak, is very helpful. Any high-speed injury should be considered a perforation until proven otherwise. Always do a dilated exam. If you can do a B scan, that's great. And you're looking for, progressive vision loss. You're not going to lose much vision from a corneal abrasion over a day or two, but endophthalmitis is different. If there's an inappropriate amount of inflammation, you're not going to get hypopyon from an abrasion. If there's a shallow chamber, an asymmetric chamber, asymmetric pressure, or hypotony, and Greg, as you really clearly said, instilling fluorescein is not really a Seidel's test. You've got to really look at it and paint it, and even put a little pressure on the globe to see if it's actually leaking. So dealing with these is, if you can photo document, it may be necessary for clinical legal purposes, but do the least that you need to. Minimal manipulation of the globe. You don't want to extrude anything, and always assume there could be something growing from whatever got in. Once you breach it, you can have some sort of organism in there. Probably avoid most topical medicines if you know what you're dealing with, because most of the topical medicines need to diffuse through the cornea. If there's a rent in the cornea, it's going to get in, maybe to toxic levels. You want to shield the eye. Don't patch it. Don't pressure patch it. A Fox shield, or even in an extreme situation, cut a styrofoam cup. Cut the bottom off, so you have a little bit of a cup, and tape that to the eye to protect it. Nothing by mouth, because they may need surgical closure. Smaller ones might be glued, and or they may actually need to be sutured. This was much too large to be glued, so he actually got referred for surgical repair, which was not the easiest thing. Nobody really felt comfortable dealing with him. He finally got in the hands of a general ophthalmologist who sutured him up. He ended up with some irregular astigmatism, but about 20/30 visual acuity. Now, one thing that you may wonder, where was all the pain in this fellow? Well, he really cut his corneal nerves. Not that Tylenol was such a great medicine, but he really sliced his corneal nerves, and that's why he went relatively hypostatic, and that's why it kind of stopped hurting him for the most part. Any final comments here, Greg?
Yeah, I think I would like to kind of echo about right there, to avoid those topical medications. I think, some of us might have lidocaine in the office. You draw up to maybe get some of those foreign bodies out, which has a little deeper anesthesia than maybe like proparacaine. However, those can be toxic to the endothelial cells. And the last thing we want to do is be killing the endothelial cells and having the patient go on to needing a corneal transplant, or a desec procedure for that. So so just be careful, as Joe's saying, that toxicity there on avoid topical medications, because it gets into the anterior chamber, it can kill the endothelial cells.
Great point, Greg. Here's one. This is what we call the sharp stick to the eye. He was a 71-year-old who presented urgently. He had been injured that morning. He had been pruning an areca palm when he bent down, and he caught the sharp end of a new shoot on his left eye. This would be a shoot, and I've got areca. I have areca palms on each side of me, and they're great. They're great plants for privacy, but these shoots. As he bent down, he caught the end of it with in the eye, and that's what he looks like. And it really looks kind of uncomfortable. He was fairly bloody. He had been dabbing and bleeding. And we take a look at this, and he actually had a fair amount of dirt in there as well. But the pertinent things here that we want to talk about is he had a formed anterior chamber. He had very minimal anterior chamber cells. His intraocular pressure was, I think, in the mid-teens. The cornea was clear, and what we're looking at here is actually a conjunctival laceration, which, compared to a corneal laceration, is what you want to encounter. Greg, do you have any clinical pearls about the conj lacerations? Besides, number one, first and foremost, always make sure the sclera didn't get breached.
Yeah. I mean, no other pearls that I can think of right now, Joe.
Yeah, these things look really terrible, but they're actually fairly easy to manage. He had a fair amount of dirt in there, so after the proper anesthesia, essentially what I did is just lavaged everything out. Good high-speed lavage, and made sure. I actually moved the conch to make sure the sclera had not been torn. I did do a dilation on him. Everything was intact internally. So in a situation like that, we got a couple options. Make sure it's clean. Antibiotics, drops, and or ointments will be your friend. I think I actually prescribed both, but I definitely used an antibiotic ointment. I essentially just took a cotton-tipped applicator. And after I got all the dirt and blood out of there, I kind of just smoothed it over. Told him to keep using antibiotic ointment, keep it lubed up. And after about a week, he was fine. He came back for his 1 week follow-up, and he resolved well. There's no pain. He still had some subconjunctival hemorrhage, but that was about all that he had left. In fact, I just had a conjunctival laceration last week. I couldn't find a good picture, but like a little this woman was doing this project that involved a small little decorative flag on a wooden stick, and she pulled it out and hit herself in the eye. She came in with a corneal abrasion. She had a uveitis, and she had a conjunctival laceration. And again, same thing, just anesthetize, lavage out, make sure everything is intact. Now, the only problem that I have, after 2 days, she was much better. Her abrasion was much better. Her uveitis was much better. She had a really big divot in the conjunctiva. I removed, on day one, I removed some of the conjunctival tissue. I'm going to see her sometime this week. If the tissue hasn't smoothed over, I'm going to anesthetize her and cut out all the devitalized conjunctiva and just let her heal. They will actually do pretty well.
So Joe, I'm not sure if you want to do the questions or you want to keep on a
Sure.
roll here.
Sure.
The one came in, I think it's about the previous case. It says, what about using anesthetic if they can't open an eye well enough due to pain to check acuity and evaluate?
Do the least that you can to get what the information that you need. The answer is, yeah, we often have to put an anesthetic in, and you put one drop in, and generally you're going to do okay with that.
Yeah.
And
If
Richard
they're
said,
leaking, it's probably going to rinse it out. So you're probably not going to get that toxicity, but I wouldn't keep dosing them. I think I'll just echo a little bit what you
Exactly.
said there. There's one that came a direct message, Joe. One says, what about pain? What are you going to do for pain?
pain, I recommend dual action Advil or I think it's Advil Dual. Right? Am I saying that right? It's a combination of ibuprofen and Tylenol. And if you dose it, if you double the dose, it really has about the same equivalency of a narcotic. I don't have a DEA. I don't prescribe narcotics, but the over-the-counter double the dose, and they'll generally do very well.
Yeah, so I can kind of chat a little bit in that arena. Is 2 and 2 is a good way to remember it. 2 ibuprofen, 2 extra strength Tylenol. In this case, I'd probably do 4 and 2. I'd probably do 800 milligrams worth of ibuprofen, which is prescription strength. You need to know your maximum daily dose. Remember, 800 milligrams of ibuprofen 3 times a day. That's 3,200 milligrams. So if you think about it, that's 16 tablets of over the counter. So they could take 4 of those 4 times a day. Tylenol is 3,000 milligrams maximum dose. So you can, in this case, because you want to try and control inflammation, 4 and 2, 4 and 2, 4 and 2, 3 times. That will help with the pain. And Joe is absolutely correct. That reaches the level of morphine. It just doesn't stay there as long as morphine does. It hits the peak and comes down pretty quickly. With a DEA, I'd probably do 50 milligrams of tramadol. That's probably like that's optometry's best friend. 50 milligrams, take 1 or 2 of those a couple times, and that would help out the pain. So that's kind of what to do with the pain. And then Joe, there's a comment regarding your laceration. I was taught less than 10 millimeters. You can observe, just get some antibiotic, and greater than 10 millimeter suture and antibiotic.
I think Richard probably means a conjunctival laceration, not a corneal
Yeah,
laceration.
that's what he's
And that's
talking
pretty,
about. Yep.
that's pretty reasonable. I just smooth it out, and I generally find that they're okay. I work with a corneal surgeon and said, yeah, if it doesn't heal, I can put a suture, and otherwise just leave it be. Yeah, it may be a little bit irregular afterwards, but who really has a handsome or beautiful conjunctiva? Really, nobody does. But here's one patching in the emergency room. She was a 19-year-old female who had developed a red, painful right eye wearing her contact lenses. Got so bad she went to the emergency room at 1 o'clock in the morning, where they patched her eye with a swab of gentamicin after trying to remove a white foreign body from the cornea. I think we all know where this is probably going. Pinhole acuity, she's 2100 in that eye. She's 20/20. She has conjunctival injection. Cornea has got epithelial excavation with dense stromal infiltration and a purulent discharge. And she looks like this. And one thing I want to stress to you, I didn't like walk her to the camera immediately. I examined her, I cleaned her up. If I clean this away within about 3 to 5 minutes, this is all back again. So throughout the exam, I have to lavage her and take a cotton tip applicator and clean it away. And after a few minutes, it's all going to come back. We have this dense white area with a lot of surrounding infiltration there. She did clearly have a pretty aggressive anterior chamber reaction. And I can tell you, she came in patched. She had been patched the night before in the emergency room. And I can tell you that when I took the patch off, I actually had to quickly step back because a large amount of mucopurulent discharge actually fell out of her eye off the patch and nearly got my shoes. So that brings me to polling question number 3. What's the most likely diagnosis? Is it bacterial conjunctivitis? Is it a corneal abrasion, contact lens overwear syndrome, hyperacute conjunctivitis or gonorrhea, fungal keratitis, bacterial keratitis, or I don't know, that's why I'm here?
Maybe go back to the picture again, Joe.
Good idea. Yeah, if you need to see, you can always just left click on the poll. You can move it out of the way. So people are thinking about this. A lot of good questions. I want to say this could be good national board question. Not an easy one. Okay, so we're hitting about 80-some%.
You can do one at a time. You can start it.
Got it for you.
All right. So if you want to, have you shared the results yet, Greg?
Yep, it's sharing.
Okay. So we got a bacterial conjunctivitis, we got hyperacute conjunctivitis, bacterial keratitis, and their fungal keratitis. We got a number of things there, and some people just aren't sure, and that's okay, because that's why you're here. We're all here to learn. I think that most people would call this a corneal ulcer. Would you agree, Greg? That most people would call it that?
I think so, yep.
Yeah. What I want to do is get you all to strike this from your vernacular. I don't want anybody to use the term corneal ulcer any longer. I don't want you to go saying, I just treated a corneal ulcer. I do treat corneal ulcers. We need to stop treating corneal ulcers. We're going to treat keratitis because corneal ulcer is a very broad, basic medical legal risk type of term. It behooves us to write down what is our thought process as clearly as you can. So when you encounter a patient like this, you think to yourself, is this keratitis? Very, very broad. If the answer is yes, then you have to think to yourself, is it infectious keratitis? Or is it non-infectious keratitis based upon your clinical experience and what you see? And if you think it's infectious, is it a microbial keratitis? And if it is, do you think it's fungus? Is it protozoan? Is it bacterial? And if you think it's bacteria, do you have an idea what it might be, a gram-negative or gram-positive? The more detailed you can be, the better. Now, if you think it's non-infectious, is it a sterile keratitis? If so, is it a marginal keratitis, an infiltrative keratitis, a peripheral keratitis, a contact lens related infiltrate, or a contact lens associated acute red eye or Clare syndrome? This is what you really need to kind of put somehow into your assessment and plan, because it shows a very, very thorough thought process. We just don't want to use the term corneal ulcer. And I'll give you an example. There's a very big difference between what you see here and what you see here on the upper right and the upper left. And there's a very big difference between what you see on the upper left and what you see on the lower one. And there's even a very big difference between this one up here and this one down here. And I hate using the term corneal ulcer. I'll give an example why. Here we have a little bit of a staining infiltrate from contact lens wear, mild irritation, patient has no vision loss. Well, I defended an optometrist in a medical malpractice suit, and it was very tough because he had a 16-year-old patient who had staining infiltrate. Now take that and put that right about there. Had a little bit of a staining infiltrate. He recommended stopping the contact lenses, prescribed Tobradex. Kid got better in a week. Sometime later, gets another infiltrate. Same kind of thing. Takes the contact lens away, prescribes Tobradex. Kid gets better. Happens 4 times, does the same thing. Kid gets better. 5th time, it doesn't look like this anymore. It looks like this now. Now, what do you think that doctor had in his record at every visit? Corneal ulcer. And the attorney said, is it standard of care to treat a paracentral corneal ulcer with Tobradex for 6 months? And it's hard to defend, hard for anybody to say, yes, that's standard of care. Now, is it reasonable to use Tobradex on a contact lens related infiltrate? I think so. But, had he not used the term corneal ulcer, they made it look like he was sitting on something that looked this bad for 6 months when he clearly wasn't. So, Greg, that brings me to polling question number 4. I think presumptively we're looking at a bacterial keratitis here. So, what is your drug of choice for this patient? Is it ofloxacin, ciprofloxacin, natamycin, moxifloxacin, gadafloxacin, besafloxacin, or my favorite, samplifloxacin? And I think with the degree of purulence that you see here and the odds of how common bacterial infections of the cornea are compared to fungus and protozoan, we have to consider we're probably dealing with a bacterial infection. Looking good, looking good. A lot of people are on their game today. They're moving quickly here. Okay, I think maybe we'll just end the poll and share the results. Nobody bites on natamycin, which is an antifungal. Think that this is fungus. Cipro's up there. Moxifloxacin, very common. Besafloxacin, very good. Gadafloxacin, we tend to forget about that. And my favorite is always samplifloxacin. If I have it, I'm going to use that. All right, well, this is a case where I actually cultured the patient and initiated moxifloxacin every minute for 5 minutes in the office and every hour while awake. I don't make people get up during the night, but if they get up, you can use the medicine. I use scopolamine in the office, and plan was to bring the patient back in 24 hours. Greg, what are your thoughts here? Would you do something a little bit different? Do you have other drugs you prefer?
No, I would stick with, Vigamox, moxifloxacin, Besavance. I typically keep atropine in the office, and yeah, it's definitely, culture this. So nope, it's no really other pearls to add to that.
Okay, well, next day she comes back. She has count fingers at 3 inches, and she has a hypopyon. Now, a couple of things I do want to point out here. Now, one thing that I really did not have at my disposal was the opportunity to refer her. One, we're on a holiday weekend. This was July 4th weekend, and it did necessitate my coming in to see her. And she's also uninsured, and she had really no finances and refused to go anywhere else. So kind of stuck here a little bit. But a couple of things I want to point out: even though she has hypopyon and a very plasmoid aqueous, I can tell you the corneal lesion really did not change in size, shape, or depth. And I think what is also very pertinent is you notice the lack of mucopurulence. That was dripping out of her eye before. Now it is no longer doing that. So what do we do next? Polling question number 5.
All right, let's get.
At this point, I would continue the same treatment, check next day, continue treatment, add a steroid, and check later. Refer, or you do something else. You put it in the chat. When I do this in a live face-to-face meeting, Greg, I always like to ask, who feels comfortable treating something like this? And some people put up their hands, and the answer is it's a trick question. Uncomfortable is how you should feel, because these have the potential to have significant visual morbidity.
Yeah, I've got a couple brewing right now at the office. A lot of people don't feel like treating them, but when you're kind of in a rural area, they're not going to Pittsburgh to see a corneal specialist. So Maria put in here, I think, a nice choice, or we need a choice. It says we need to get something that the insurance will cover, the patient's insurance will cover. Yeah, I would agree somewhat. There's times whenever the patient has to bite the bullet and pay that $60 to $80 to $120, for that 4th generation, fluoroquinolone. We just had to do it this week with Besavance with a infectious keratitis, not corneal ulcer. So there's times whenever these serious conditions come in, you just got to explain to the patient it's serious and sorry, we'll got to spend the money on this one. I would try and take the shortcut if we could, but we gotta, make sure we try and do that.
Yeah, my wife had a patient who was just out of incarceration who developed infectious keratitis, and my wife was treating her with samples of Besavance, and you get 3 or 4 drops out of those samples; they just don't go anywhere. And the patient was still struggling, and my wife asked me, "What do I do? I don't have any more samples." She is just out of incarceration and practically homeless. I can't. I said, look, if you think Besavance is the best thing, write a script for her. Also, write her a script for Ocuflox at $9 and tell her which one you think is better, and explain the situation. Well, the patient went out; they got Ocuflox. What happened? They got better. Now, in this case, it was mostly the worsening inflammation. I continued the Vigamox hourly, added some Pred hourly, but I brought her back 6 hours later. And she comes back 6 hours later. She's a little more comfortable. The ulcer is not worsened with the use of her steroids. So we continue the medicines. 24 hours, she did come back positive for Pseudomonas, and it was susceptible to most antibiotics, including the gentamicin they used in the emergency room. And she got a lot better. So ultimately, over the course of another 24 hours, the hypopyon resolved, the inflammation came down, the cornea healed pretty well. Yeah, it took a few, about 2 weeks to get everything healed on a patient like this. Bacterial keratitis, bacterial infections of the corneal, you get a breakdown from trauma or hypoxia from the contact lens. It allows the pathogen to get in. Once that pathogen gets in, and by and large, the most common thing that we face are bacteria. If you were to send a patient who ultimately has a fungal or protozoan keratitis to a tertiary medical center, they're going to start treating as it's a bacterial infection, because that is the most common thing that we're going to see. So the organism is toxic. The collagenase that it's releasing is toxic to the cornea. You get this antigen antibody response. It's an inflammatory response. You have infiltration of the cornea. Hopefully the white blood cells will phagocytize and digest the bacteria, but when they release their collagen-lytic enzymes, it's damaging the cornea. So hopefully we get antigen neutralization, but you're going to end up with cicatrization, scar tissue formation, and vision loss. And you can have a lot of inflammation, and it's a very wide presentation depending on what organism that is involved here. Culturing is what everybody advocates is what we should do if there's a risk of visual loss or visual morbidity. There's a broad spectrum of antibiotics we can use. Historically, we have always used aminoglycosides such as tobramycin fortified and like cephalosporins, vancomycin, that is really for parenteral use and put into an eye. Very, very toxic. And that's what we've always done, but there's never been any studies that show it's any better. We've just been doing that since, the antibiotics that we had many years ago really weren't that effective over the counter. And these were anointed the standard of care under the guise more must be better. Nowadays, we got some approved medicines such as ciprofloxacin and ofloxacin, which are both actually approved for bacterial keratitis. Later generation moxifloxacin or gedafloxacin are pretty darn effective, but they've never actually been approved for bacterial keratitis, only bacterial conjunctivitis. iQuix is a fluoroquinolone that is also approved for infectious keratitis, as well as besafloxacin. Cycloplegics, cold packs, corticosteroids are all very helpful. It wasn't until the fluoroquinolones came out that they actually started making comparisons and studying and comparing the fluoroquinolones to fortified antibiotics. And what they actually found was even the early generation fluoroquinolones, the ofloxacin and ciprofloxacin, and then moxifloxacin and gedafloxacin, were really just as efficacious as fortified antibiotics in treating these things. Now, there's always been that concern about corticosteroids. Aren't they contraindicated? If you suppress the immune system, are you going to let this thing get worse? Are you going to harm the patient? And maybe there was a time that we had to worry about that a little bit more, simply because some of the antibiotics weren't really all that effective, but now they're really pretty good. So if you can reduce the inflammatory response with steroids, you can actually have a quicker healing time and a better corneal outcome. Now, when's the best time to use it? After the bacteria has been suppressed to some degree, and we can use that with a culture and sensitivity report, or if you just see the patient, think they're just getting better. And about the 24 to 48 hour starting point is really where it's going to be beneficial. But there are some good studies out there that have actually looked at that, using the fluoroquinolones alone or fluoroquinolones with steroids. And some of the early studies really actually were pretty helpful, and they kind of showed that early addition of steroids to an antibiotic treatment doesn't seem to be harmful when watching the patient very closely. Sometimes you may not have any statistically significant differences in final visual outcome or healing, but when you ask the doctors who are involved in the studies, everybody pretty much, kind of agrees that these patients who are using steroids and tolerating the steroids along with antibiotics seem to be doing very well. And it really brings me to what was the biggest study for this, the SCOT study. There's a part 1 and a part 2. And this was a steroids for corneal ulcer trial. This was actually a multi-center study that was done in India because of the nature of the injuries and the infections. And it looked at 500 patients who actually had a culture-confirmed bacterial keratitis. And everybody got topical moxifloxacin, not fortified, but topical moxifloxacin. And then either they got a placebo or predphosphate. And, the outcome was what was the vision at 3 months, how long did it take to reepithelialize, and what did the scar look like, how big was the scar at the end, and did the patient perforate? And ultimately, they really found no differences. They had no safety concerns using steroids, but they actually saw no difference in outcome of best corrected visual acuity. And their conclusion based upon this was the adjunctive use of corticosteroids doesn't really seem to improve the outcome at 3 months in terms of vision. Now, Greg, have you ever put steroids on eyes that you've diagnosed with bacterial keratitis after you've had a period of good antimicrobial therapy?
Within the last 2 weeks, yes. I have a nasty
these
corneal ulcer that we got going on right now.
I'm sorry, what did you say?
Corneal keratitis, sorry.
Thank you.
Infectious keratitis, sorry.
And do you feel these patients do better?
I do. That's why I did it.
I do as well. There are some shortcomings of this study. The regimen of steroids was really pretty conservative. It was predphosphate 4 times a day for a week, twice a day for a week, once a day for a week, after 48 hours of using the moxifloxacin. Now, they didn't look at quality of life, patient comfort level, or how long it took them to, get functional vision where they can recover and go back to work. So it did improve if you look at some other things. Now, here I thought was the most important thing, a little footnote. There was a subgroup that did actually benefit from steroids. They had the worst visual acuity and central ulcer location at baseline. These are patients, when they were giving steroids, had a better outcome. Now, what I want to point out is the majority of the ulcers in the study did not look like this one in the right. They looked like this one on the left. And you can see that you have an infectious keratitis here. You put them on steroids and antibiotics or antibiotics alone, what's the difference going to be at 3 months? Virtually nothing, because there's very low risk of visual morbidity. Both are going to have a pretty good outcome. But these patients, they actually had less scarring. Greg, that brings me to polling question number 6. I'm interested to see this one. Yeah.
So while I launched that, I got 2 private direct messages here. And then we have a question from Heather. The first one, that's a direct message, says, why add steroid to bacterial keratitis? Sorry, I lost sound for a minute and missed that part.
Well, the reason is that the bacteria and their collagen-lytic enzymes are actually pretty nasty to the cornea. And if you can exogenously remove the organism, the inflammatory response is actually damaging superfluous. It actually helps them to heal and makes them better. It makes them feel better.
And then the other one is steroid on staining cornea, question mark.
The answer is yes, as long as you're well covered with antibiotics. If you wait for the cornea to completely reepithelialize, the benefits of the steroid will be lost.
And remember, the cornea can't reepithelialize when there's a war going on, whether it's infectious or then it turns inflammatory. So I think one of the things that I would point out is that Yeah, and there's really no, I guess if you want to say scientific way, unless Joe, you know, a scientific way other than evaluation and monitoring, is that you want to get reversal. And Joe mentioned about, 36, 48 hours, 24 hours of using, antibiotics. By that time, you should have that. If it's not resistant, you should have that bacteria neutralized from infectious to now you're going to have an inflammatory event. And that's when the steroids come into play. Now, I can tell you this nasty corneal keratitis that I had, this infectious keratitis that I'm dealing with, when I added it, I had Besavant 6 times a day, steroids 2, right? And I watched it like within 12 hours to make sure that the cornea wasn't thinning. So it wasn't like I went 6 steroids and 2 Besavants. I added very cautiously and followed cautiously. When that steroid goes on, every 12 to 18 hours, I'm watching it to make sure that cornea is not thinning. So that's, and then now they're sitting at, 4 and 2. Flipped now, they're sitting at 4 steroids and 2, and that wound is finally closing.
And don't underestimate the 9 a.m. follow-up and the 3 p.m. follow-up on the same day if necessary. But always remember, when if what you have should be working and it is not working, you also have to consider what else can it be, namely fungus and protozoa. All right, we got a good in here, good response. And let's end the poll and share the results. And do we culture in practice? Yes, frequently very low. Yes, but rarely, a few more. And the majority do not culture in their practice. Well, that's about what I expected to see. I'm going to talk to you about culturing. And what I'm going to talk about is PCR culturing, polymerase chain reaction. This really allows for a rapid and pretty specific diagnosis of infectious diseases, including bacteria and viruses. So you can identify, slow-growing microorganisms such as mycobacteria, anaerobics, viruses from culture assays, and even animals. Greg, I know you sent me a text last week or earlier, and I told you I was going to talk about this. This is my culturing right here, right? I actually culture all these lesions now. It isn't hard. I'm going to share with you how to do it, and it's actually very elegant. This is all my culturing right here. I've got a UPS because it's going to be sent out. Everything is going to go in this little plastic bag. This is a label maker that we put the patient's name and information on this transport media, and we culture with the SteriFlock. And this is the new generation of, I guess you say, culturette. And this is what it looks like when you put it under mag. It's not your little cotton tip applicator. It's like a little Brillo brush. This is you can actually denude a cornea with this. This looks like a Q-tip. You don't want to be putting that in your ear to clean out your ears, because you can actually debride a cornea with this. You can get into the lesion and you can scrape it out, and you're going to get tissue. I will also take an epithelium scraper, scrape a little bit more of the lesion, and just plaster it on there. And you can even put 2 in there. You snap it off, seal it. Our lead technician knows how to do this. She gets the patient's insurance information. She calls for a pickup, calls our local rep. They arrange for a pickup. And it's fast. If you are seeing a patient Monday morning at 9 o'clock and you do this, and you see a patient to follow up by Wednesday afternoon, you're going to have the results back. It comes back fast. And here's what they're testing for in this: acanthamoeba, aspergillus, candida, Epstein-Barr, cytomegalovirus, fusarium, Neisseria, strep, pyogenes, Enterobacter, Haemophilus, Pseudomonas, Streptococcus pneumonia, chlamydia, Demodex, Bacillus, Mycobacterium, varicella, test for Corynebacterium, test for everything. Now, caveat, it's only okay for fungus. It's not wonderful for fungus. It's okay for fungus. And this is what comes back. And this is one of my recent patients that came back, detected 600,000 copies, which was a moderate infection. And it tells what is our susceptibility. Now, here's a small issue that I have. Not many ophthalmics at all are tested. You've got anything that's OP, ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin, azithromycin. So they have a relatively limited number of ophthalmics that they test for. But I mean, it's fantastic. Everything is, it just takes a few moments. You get a lead technician who knows it. This company does all the work for us. You know, we call the rep will arrange a pickup for us. And it's back in, you get the results in about a day and a half, 2 days longest. And it really works extremely well. The company is called Health Track. Health Tracks is healthtrackrx.com. I have no relationship with them. I use their services. I find them very, very good. It all gets shipped out to Dallas, Texas. The turnaround time is a day and a half to 2 days. Nothing has taken me more. I mean, if you're 4 o'clock, on a Friday, you're not going to be getting it back until Monday. But 4 o'clock on a Wednesday, by Friday morning, you should have the information. They bill the patient or they bill the insurance. You don't take any issue there. The cost of the patient has to pay out of pocket is $125 to $150, somewhere in between there, but no more. And always bill a procedure code 65430, scraping of the cornea, diagnostic for smear culture. The allowable is $109. So the answer is I culture all of these now. It's a great service. It's a great company. It's fast. It's effective. It's easy. They supply everything. You don't have to buy anything. You set up an account and they will get you started on this. You can culture all of these and it's very helpful. And you see what we have right here? These things that we always wondered, is it infectious? Is it non-infectious? I can tell you right now from doing this, it's infectious. They're all coming back as infections. Would I consider a pro-care? Absolutely. Keith said they all come back Staph aureus. It's not uncommon. It's the most common thing. Say you use a steroid and a keratitis with a 4th generation fluoroquinolone in the South and turn into a lawsuit. With the use of a steroid hold in court is part of standard of care. The answer is most likely yes. Question: how do you culture contact lens, case, cornea? I go right to the cornea. In a lesion like this, I can actually debride that whole area right there, maybe a little bit more with that Brillo brush, and it picks up a pretty good amount of inoculum. Is it true that gentamicin has the same effectiveness against MRSA? Greg, what do you think about that?
I saw that question. I don't know. I was kind of hoping Tracy was with me on that one.
Mhm.
I'm not sure if there's any. I can't comment. So,
Actually, one thing that has the best effectiveness against polysporin, polytrim has actually some pretty good effectiveness against MRSA. One of the best things is chloramphenicol. Chloramphenicol works beautifully against MRSA. In fact, it's just not that easy for us to get it, and it's not as readily available.
like you said, trimethoprim, doxycycline, they all have some good against MRSA.
Question came to me: how many times does a culture change your treatment? It doesn't necessarily change my treatment, but it reinforces what I'm doing. I feel better about using the steroid, and at least that way I know that my presumption of what I'm doing is right. If it comes back as a fungus, well, that's going to change it. If it comes back as no organism and it's clearly getting worse, then we're probably dealing with something that it's not catching, which could be fungus or protozoan.
Or you didn't scrape hard enough.
Exactly.
Go back to your report, Joe. The other one, the resistance. Because I'm going to start using this. I use a hospital. The one thing reason why I texted Joe is because it's PCR, it's rapid. You're going to get it back fairly quickly. And I like the idea that you can get some fungus back, even though you said it's good. Because remember, everyone out there, that fungus is, if you have someone that comes in and they notice something on their eye a day ago and now it's 3 days, it's likely not going to be fungus, because fungus takes forever to kind of get going, and it's slow to grow, and it's slow to get rid of. Back in the day, I treated 3 fusarium ulcers, from whatever that was, moisture lock. And, each of those 3 patients I saw for a year, because it's slow to grow and then slow to get rid of. But the reason why I wanted to see this, Joe, is because someone said about, would it change your treatment plan? And when it changes my treatment plan is whenever I see resistance or low susceptibility versus high susceptibility. So absolutely, me knowing the bacteria, probably not. Me knowing the susceptibility, high susceptibility versus medium versus resistance, that's going to change sometimes what I'm doing. So it can change the way you the culture itself, the bacteria or the whatever you're growing, probably not, but the susceptibility will probably change you. Yeah, and you have it right up there. I could see the report. It says best activity, good activity, and variable activity. So right there, looking at that is probably what would consider me to change my treatment plan. All right,
So
this what I
private
wanted to see.
A private message, am I now culturing all keratitis? The answer is yes. I mean, I'm not gonna culture something that I look at and I know is really just a sterile infiltrate from a contact lens. Person's got a white quiet eye with a little bit of an I'm not going to do that. But the cases like this, I'm going to culture something like that or anything even similar to that, and it kind of tells me some good information. So the answer is I will do that.
And I would say, with PCR now, because you're getting it back so rapidly. Back in the day when, it took 10 days to get the results, you're not going to wait 10 days to do treatment. By the time you did the treatment, by the time you got the results back, you probably had it healed and it didn't change. But PCR is a game changer. If you're sending something out Monday, having it by Wednesday, that's some good, valuable information based on that good and what, the good and the moderate and the no activity that's out there. So I think PCR is the key here, that in this culturing, that it's not just regular, like right now, the reason why I called Joe is, I take I got a bunch of culturette tubes. I take a bunch of culturette tubes. I have my staff drive over to the hospital. I talk to the lab and I say, look, I'm trying to grow whatever here. You do blood auger, chocolate auger, regular auger, all whatever medias there are. Yeah. And, by about 7 to 10 days later, I get a report. By that time, I know I can see what's going on, but by that time I get the susceptibility, and that might change what I'm doing. But it's just such long. Go ahead, Joe. I'm sorry.
Yeah, no, these new culturettes, as we call them, they're like little Brillo brushes. They help you can get inoculum. It really can scrape off the cornea, and it's very fast. Question: the inferior, infectious marginal keratitis that I found to be infectious, would it change my use of steroids? No, probably not. As long as I find out what it is and I know my antibiotic is working by 2 days, the use of a steroid can help them, unless they're feeling better. If they're feeling okay and they're responding, then if I don't think that they're going to benefit from a steroid, I probably wouldn't put it on.
Joe, when I called the company, and this was last week, and they were going to call me back that day, and they haven't called me back, but they did ask if I was CLIA, and I said, look, I do CLIA testing, but I have a CLIA waiver. So, where you work, do you know if you need to be a laboratory to be able to do this, or
no? You do not.
They seem to be the lab. So,
you do not.
Okay.
And the great thing about it is, they do all the work. My lead technician knows the system. She calls the local rep. Local rep arranges the UPS pickup. They do all the work.
The other comment here, Joe, that I'll make is, someone put in here, would you use a Procara? And, so let's just real quick, I'm not going to turn this into my hour amniotic lecture, but I would stick with Procara because if you read the package insert, it's indicated for corneal keratitis, infectious keratitis. And if you look at a dehydrated, and you can pull any of the dehydrated package inserts, we as geeks and lecturers read those package inserts as speakers. And if you read the package insert of a dehydrated, it actually says contraindicated for an infectious keratitis. There is a difference between dehydrated and cryopreserved. So Keith, or whoever put that in there, sorry, it moved. It wasn't Keith. It was Matthew. I agree. Procara cryopreserved over a dehydrated where it says it's contraindicated. Just read the package insert.
All right, well, next one is a 23-year-old male with bilateral redness and a little bit of discomfort, or actually a little bit of pain, with a sticky discharge. His lids were glued shut when he wakes up. He has a fair amount of discomfort and photophobia and kind of blepharospastic. Begun several days ago, getting worse, right eye first, then left eye. His acuity is 20/30 inch eye, and what we see is a pretty good conjunctival hyperemia and a keratitis, papillary hypertrophy, a little bit of anterior chamber action, no lymphadenopathy, and he looked like this. And you don't really get a chance to see something like this that often. And he's got really quite a bit of, almost like hemorrhagic conjunctivitis. He's got a really significant mucopurulence, and you clean that away, and within about 5 minutes or so, you got that accumulating again. And really, he's got a bacterial conjunctivitis, or because his cornea is involved, it's more like a bacterial keratoconjunctivitis. And there's a breakdown of his, his defense system, setting up this antigen antibody response, and it's inflammatory in response to the bacteria and their exotoxins, and the exotoxins are going to alter the metabolism. And if you have a fair amount of discharge, that will be toxic to the cornea. So the punctate keratopathy is really from that mucopurulent discharge, and that's really quite an irritant. It's dead bacteria, it's white blood cells, it's exotoxins. Greg, how often do you actually see a true bacterial conjunctivitis in practice, that where you look at and you're just absolutely sure?
3 times a year.
Yeah, it's not nearly as common as we probably were led to believe. But true bacterial conjunctivitis are pretty uncommon because the eye has such a very good corneal, good defense system. Now, when the cornea gets breached, that is privileged avascular tissue. Things can get kind of nasty there. So you can have some discomfort. Usually it's a painless unless their cornea is involved. If it is, you can have this coarse punctate epitheliopathy. The lids are going to be glued shut, not dry and crusty, but really thick and matted, because when they sleep, it's a nice warm environment. The lids aren't shearing bacteria off. They really proliferate, and that is going to extrude through and really matter up the eyelashes. And I said, if there's a lot of purulence there, they're also going to have some keratopathy going on as well. So some of these heavy loads or virulent organisms, if they're unusual, can be sometimes hard to eradicate without a little bit of ocular damage. Our concern is we don't want it to progress to a corneal infection. And because most of these are going to drain through the nasal lacrimal system, you don't really have a lymphadenopathy like you do in a viral unless they have really a hyperacute situation. And the question was, what about in children? Well, in children, one of the more common things that we're going to see is actually H. flu or Haemophilus influenza. But for the most part, the natural defense system will eradicate unusual bacteria, even the normal flora, which can sometimes overgrow and give you a true conjunctivitis. That normal flora is going to be an inhibitor or a competitor for other potentially more virulent invading bacteria. So real common organisms, Staph aureus, H. flu, strep pneumonia, and Pseudomonas. Interesting, Pseudomonas gives a relatively mild conjunctivitis. And I think we know that it gives a really nasty keratitis, but conjunctivitis, Pseudomonas, is actually relatively mild. If you've treated bacterial conjunctivitis, there's a very good chance you've treated Pseudomonas. Any thoughts here, Greg?
I'll just say, kind of a rule of thumb, if you're, in children, you said H influenza, that's gram negative. Usually geriatric population, that's, gram negative, and then kind of your adult population or your gram positive. So, going something broad spectrum that's out there, cover a lot, but, just kind of remember both ends of the spectrum: children, geriatrics, gram negative, adults, gram positive. So
now, one of my former students, Brittany, asked me a question directly. Hi, Brittany. Isn't this a potential gonorrhea conjunctivitis that could potentially perforate the cornea? That is an excellent comment. The answer is you consider it, but I call this acute bacterial. I don't call it hyperacute. There is a pretty good difference, and this is kind of the difference here, is the amount of mucopurulence. I can tell you right now, I've actually seen hyperacute. So I'll give you an example. 18-year-old male came in with a bath towel dripping in mucopurulence from cleaning his eye. I couldn't even see his eye because there was so much mucopurulence. I would actually clean it out. I didn't have much more than a few seconds to look at the eye and examine the eye before I had to clean them again. And that is one of the ones I'm going to culture. That was an unusual presentation. I cultured that one, and ultimately it came back not as Neisseria as I thought it would be, but it actually came back as Corynebacterium diphtheria. So not all hyperacute conjunctivitises are due to gonorrhea, but Brittany, it really wasn't that bad to me that I would call that a hyperacute and think about. Yeah, I ponder the idea that it could be Neisseria, but we're ultimately going to be treating the patient much the same way.
I just changed my Joe. I just changed, just so you know, I have some Uber Eats coming, and I changed my salad dressing from honey mustard to something else now. after seeing that picture,
vinaigrette. In a case like that, usually I don't culture these. We can usually treat them immediately. My culturing is for cases that are worse than this, or if they're not responsive. The fluoroquinolones are great. For every 2 hours to 4 times a day. I'm not worried about bacterial resistance. Polytrim, Tobrex, and erythromycin probably are actually pretty effective. Now, what about something like a combination, Greg, like Maxitrol or Xylate or Tobradex? Would you use in a situation like this?
Probably not initially if I knew it was bacterial keratoconjunctivitis in the infectious stage. I would probably wait to get some reversal and then and I probably wouldn't even do a combination. I'd probably just go straight to a steroid. So
now, one of the best things you can do in a situation like this is actually tell the patient, clean yourself, get rid of it, clean it. Hyperacute are going to be a lot more severe. Neisseria, Corynebacterium, these are all things, and they're not, not all hyperacute are going to be sexually transmitted. We do want to consider getting a good history, see is there any at-risk behavior, and really anybody who is, sexually active or participating in sexual activities with somebody else that falls under a possibility. But the history can be unnecessarily complicated. Sometimes a partner or family member may be in the exam room, or they may have came into the exam room or asked, requested to be in there. You find yourself in a situation that you have to extricate yourself from and separate the patient. And sometimes patients just don't get it. I've tried to, I've been in situations where I tried to explain it or ask the question. I don't get very reasonable answers. Like this fellow here, I said, are you sexually active? And his response was, no, not really. And, after a while, I just kind of gave up on that one. I knew I wasn't going to get a very good response to that. So a couple of things to remember: bacteria can initiate this inflammatory reaction. The antibiotics will eradicate bacteria, but they don't do anything directly for the inflammation. Sometimes a steroid may be necessary later in. Don't confuse crusting and matting of the lashes. And always remember that bacterial conjunctivitis is not really common and it's self-limiting. In fact, a study came out a few years ago that said that after about 3 days of a bacterial conjunctivitis, the use of antibiotics were unnecessary. Now, the author said, advocated still treat, but after 3 days, the immune response is doing its job, and the outcome is not going to be any different than if you use antibiotics or you don't use anything. And be aggressive in contact lens wearers because of the risk of pseudomonas and leading to infectious keratitis. And one thing to always remember: exotic lifestyles can lead to exotic conjunctivitises. So always remember that. Anything else there, Greg?
No, we're caught up on questions.
All right.
We're good.
Well, here's a pretty straightforward, I think, simple one. 30-year-old female presents as an emergency patient with her eyelids stuck shut. She had LASIK 6 months prior and was using Alrex for dry eye. She's got profuse tearing and pain at about a level 8. And, there's the Alrex she was using. And she also had in her medicine cabinet nail glue. And if you look at it, about the same size, both have a pink cap. And look, it even says eye lure. Eye is in there. And that's what she's dealing with, is chemical tarsorrhaphy. So
Exactly.
she glued her eye shut with nail glue. You're laughing, Greg. I'm sure you've encountered this before.
Yeah, quite a few.
Yeah, I think everybody has probably encountered this once or 12 times in their career. She's not seeing too well because of visual obstruction or tarsorrhaphy. How do you handle these things, Greg? I mean, what do you do here?
With the glue in the eye?
Yeah.
Yeah, the good news is the super glue typically doesn't stick to the conjunctiva or cornea. It does really well. If we all know, with our fingers, we glue our fingers. It glues the eye lid pretty well. I don't know. I kind of use forceps, Joe, different gauge needles, and try and soften it up and slowly, pick away, and without, cutting and damaging and losing too many lashes, just try to slowly get this eye open. But that's pretty much the good news is, I don't have to, sometimes I'll cut it with some forceps, like that one there. You can maybe cut it and get it open, but maybe you have a different trick up your sleeve that
moisture is our friend. Very, very soppy wash rags. Keep it moist. It will eventually it'll eventually come apart. If you can put a lot of fluid in there in the office, ointment will be your friend. Some forceps, you might be able to start peeling it off. But generally speaking, the cornea is okay, and her LASIK flap was undisturbed, fortunately. Well, here's what I call a very stealthy situation. Patient's a 47-year-old male who was 13 years post-LASIK surgery. Prior prescription was about a -10. His complaint was decreasing vision in the right eye for about 18 months. There is a gradual regression of the LASIK in the right eye only about the last 3 to 4 years. Now, his best corrected acuity reduced from about 2015, which was what he was after LASIK, to about 2070 over the last 3 to 4 years. And he's complaining of monocular diplopia. So medical history is unremarkable. He was a very high myope, -10. Post-LASIK surgery did very, very well. But over the last 18 months, the vision's been drops down to about 2070. There is a regression in the right eye for only the right eye for about the last 3 to 4 years. And that brings me to polling question number 7. What do you think is the most likely issue here? Is it keratoconus, post-LASIK ectasia, severe ocular surface disease, keratoglobus, cataract, something else?
Got him.
And we're caught up in questions, I assume. Good.
Yep.
Okay, good number of people are coming in.
I'm gonna let you end it. I'll put the handout back in there again, Joe.
Okay. We're close up there, so we're going to end the poll and share the results. Keratoconus, you got to consider post-LASIK ectasia. A lot of cornea got lopped off, that 10 diopters. Ocular surface disease, keratoglobus, cataract is there, maybe something else. Okay, great. Put that handout in. Okay, well, let's look at additional testing. Pupil testing, normal, no afferent defect. Color vision testing, full, symmetrical. Biomicroscopy is normal. No corneal thinning, no endothelial disease. Lenses graded as clear and symmetrical by several eye care physicians, including optometrists and ophthalmologists. Topography, normal. No irregular stigmatism. RGP lens over refraction, no improvement. Threshold perimetry, full in each eye. OCT, normal macular architecture, no abnormalities. Fundus evaluation by a retina specialist, pristine and perfect. MRI, deferred for now. Now, let's go back and look at that refractive history. In 98, it's -1/4 in Plano, 2015. In 08, -75 and -1/4, nothing unusual there. 2009, -150 at 20/30 acuity. 2010, -3, 20/50 acuity. Left eye is maintaining pretty well. 2011, -5, and now dropped down to 20/70, still at doing pretty well in the left eye. If anybody has any ideas, I want to put in the chat room, put in the chat, go right ahead before I say anything further. Greg, you have any thoughts here?
I'm thinking lenticular at this point.
Okay, here I'm looking in the chat. A couple of people say cataract, NS. Okay. When in doubt, we got to sometimes do it the old-fashioned way and examine the patient. And this is what he had. Actually, you can see this little dense nuclear sclerosis. Now, the interesting thing is, clear view of the fundus, pristine view. You can see perfectly through there. But when you look right there, off axis, thin beam, you see that real dense white nucleus. Sometimes we call that Milky NS. Now I'm going to break HIPAA privacy and tell you who the patient is. It was me. Now, I tell you, I tortured my residents. They were refracting me every other day. I was doing my own evaluation. I was doing my own OCTs and running visual fields on myself. I was about to write myself a note for an MRI. One thing I couldn't do is I couldn't look in my own eye. And that's what I had. I had a dense nuclear cataract. Now, if you were to go to Google and you Google Milky nuclear sclerosis. One of the first images that come up will be this image right here, and that is my eyeball. I can tell you, I've seen that in many other people's presentations as well. And this dense milky NS is very deceptive. It's not like your uniform NS that happens as part of the aging process, but it's really just that very central area there. And it really can show up. It's not, it's not that like the view in equals view out. You get a very clear view in. I had a terrible view out. I could pinhole. I actually had monocular diplopia, or I call it triplopia. I'd actually see 3 images with that eye. So this is really a unique type of cataract. It's not really well described in the literature as a distinct clinical entity, but it's got that dense nuclear opalescence, and you have to be very careful and be specifically looking for it. In my former area, the person who saw this the most was actually our clinical neuro-ophthalmologist. Patients were referred in from optometry and ophthalmology for unexplained vision loss. It will give a dramatic myopic shift. I've seen it in other patients of 5 diopters and more. Very significant visual impairment, but a very clean view of the fundus. You're not really even going to believe it could be cataract. But there may actually be a bowing effect of the slit lamp, because there's a significant refractive indices difference when you look through here. It almost gives you this type of bowing with your slit lamp beam. You can actually see where it is bowing outwards. Now, the patient initially refused to accept the diagnosis. Can't be a cataract, not in me, not in my 40s. I did eventually acknowledge it was a possible cause. I underwent phacoemulsification with IOL single vision implantation. I was 26 hours after surgery. I was 15 uncorrected. Ultimately, patient did accept cataract as a potential diagnosis. So, not all cataracts are created equal. The view in does not equal the view out in this condition. In most patients, we should look at a cataract, and we should be able to predict what their visual acuity is. Several people, including ophthalmologists, looked at me, never saw anything unusual. Extreme refractive shifts. Hyperopic, you got to think of retrobulbar mass. Myopic, nuclear sclerosis, fluctuating, possible diabetes. My area, the neuro-ophthalmologist was the one who saw most of these cases. Always remember the M's: myopic, male, middle-aged, myopic shift, and milky NS. You put that all together, this should keep you out of trouble when you come across this unique type of cataract. Greg, any thoughts there?
Yeah, a couple thoughts. One is HIPAA is HIPAA as the third party chair. It's so that's one of my pet peeves. But anyway, I get back to being on track and talking about your case here. Another way you might want to consider that type of cataract is sometimes called an oil drop cataract. So that one's tough to see. And I just kind of want to echo a few things that you said, Joe, is that, think of the lens as being almost a double lens. And that's why Joe ended up with that double and triple vision, because it's that index of refraction that changed. Remember when we studied all about that in lenses, plastic versus glass versus water versus air, the index and how light bends, is that index of refraction of that nucleus changes, and it is surrounded by that cortical, which has a different index of refraction. So that's where, you kind of get that myopic shift, and that's why it's hard to see. And that's why, you kind of get that double or triple vision, because you literally have a couple lenses in there, and depending how the light is hitting, that's what the patient sees. Oil drop, milky NS, index of refraction. And I think we lose a lot of them is because, your autorefractors will get a good reading because it's clear, but the best way that I've learned how to diagnose those is with your retinoscope. And I keep my retinoscope charged up, and I use that all day long looking at corneas. I don't refract with it, but I see a lot of disease patients and learning that reflex. And that was great back in the day. And that helps me out of knowing what's going on, and kind of what you said, Joe, how that, that light kind of bends on the retina. You can kind of see that when you're doing retinoscope on them, and even direct, you can see the oil drop kind of shape. So those are my pearls.
Yeah, Rich has a question that I'm not sure I have a good answer for optically. Had a dense cataract without the myopic shift, so why not? I've seen many, nuclear sclerotic cataracts many times. Usually you have a little bit of a myopic shift. It's not a lot. These have a very unique amount of, several diopters over a relatively short period of time. And yet the density, does not affect your ability to see the fundus. So I don't really have a great explanation as to why this is so unique, but it is a kind of distinct little entity. So I think I'm going to wrap up now, Greg, with a quick case here. It's what I call not a bright idea. He is a 59-year-old man who came to me with a red, painful, and very photophobic left eye of about 10 days duration. No real history. He mentioned a cosmetic eye whitening procedure bilaterally 5 years earlier. Something he mentioned that I didn't recall or recollect ever hearing that. But he is convinced that he just had dental work and he had 2 badly decayed teeth removed, and he felt he had some sort of spread of infection from his decayed teeth, and had been put on topical polytrim, I think, by a walk-in clinic, and it wasn't really doing much for him. He was 20/40 right eye, finger counting left eye. He had a really profound, deep injection. Now, looking at him, he had about a grade 3 cell and flare, a lot of flare involved, good amount of stromal edema, keratoconjunctivitis precipitates, almost near complete secluded pupil with posterior synechia, a really dense nuclear cataract, pressure of 34 in that eye, fellow iris 18, some temporal conjunctival and scleral thinning, calcific plaque in that area, and I couldn't see anything in the fundus. And he looks like this. I'm not going to do any etiologies here, but when you see this, Greg, what are your thoughts here?
Well, I see a lot of, I can't tell if that's infiltrate down there in that right eye. That looks thinning there over there on that left picture. Yeah, I'm getting a little concerned about, some thinning of some sclera here. So,
yeah, you can start to see some of the uveal tissue. There's actually a very calcific plaque there that was removed by forceps. So he's got a lot of inflammation, a fair amount of pain. He really thinks that this is from his decayed teeth, and he's got a spread of infection, but don't really think so. I'm going to hit you with polling question number 8 and see what we think that this could be.
Joe, did you say there's a lot of pain here or not?
Yes, it was very painful.
Okay.
So what's our diagnosis? That conjunctivitis, uveitis, scleritis? Is it a abscess from his dental procedure? Or I'm not sure that's why I'm here. So people seem to be fairly with us tonight.
Maybe go back to the picture while they're rolling in.
Oh, good idea. Brett made a comment, untreated rheumatoid arthritis lead to scleromalacia perforans. Right, excellent thought. Certainly have to probably consider with this condition, what we're looking at here, maybe some autoimmune disease. That'd be first and foremost. I'm not going to question people about the suspected etiology because it's not an easy one. All right, a lot of people have responded, so we end the poll and show the results. The majority of people are thinking scleritis, okay, anterior uveitis. We're not really thinking too much about anything else there, but the strongest is anterior scleritis, and I certainly do agree. And as Brett says, untreated rheumatoid arthritis, no history of it, but leading to a scleromalacia perforans. Very good thought. Diagnose anterior scleritis, treatment, difluprednate, Durezol. Really an excellent medicine when we're dealing with scleritis. I've actually used it in several cases and it works very well. And now that Durezol or difluprednate is generic, it is much more affordable and easy to get. Atropinize the patient twice a day, Combigan twice a day, oral ibuprofen. And Greg, why don't you hit everybody else up again with your cocktail ibuprofen and acetaminophen?
Yeah, so again, you have to remember the upper limits, and I'll say it again. Ibuprofen is 3,200 milligrams, right? So Joe has 800 milligrams there. So if you write for prescription strength ibuprofen, you want to write to a pharmacy, that's 800 milligrams 4 times a day. 8 times 4 is 32. You can use over-the-counter ibuprofen, but you're going to give 4 tablets of that. So that's what you remember for ibuprofen is 3,200. The upper limit for Tylenol back into about 2014 was 4,000 a day. They changed it because of the liver toxicity. So it's now 3,000 milligrams a day. And so if you do 500 milligrams, you can do 500 times 2, that's 1,000. You can do that 3 times a day. A lot of the times I treat people with 2 and 2 because I'm just trying to get that analgesic. So 2 and 2 is analgesic, and then they don't get it confused. When I go 4 and 2, I make sure I write it down because I don't want them taking 4 Tylenol. I want them to take 4 ibuprofen, 800 milligrams, and 2 Tylenol, 500 at 1,000. And that 8 and 1,000, that's where Joe was referencing. It gets to that morphine level that's there. So that's that combination.
Question comes person's a GI bleed or a thrombocytopenia. What can they take? What could they take if they had this condition?
I would, I'd reach out to a pharmacist or reach out to a primary care doc first, but I would probably go with tramadol. It's probably pretty safe to go tramadol. I'm not sure, Joe, in Florida if you have DEA, but remember that's tramadol is very safe, and it's not that it can't create addiction, but it's on this, it's a category 4. So
ultimately, something like this should be in the hands of a rheumatologist now. They may need methotrexate. They may need Cytoxan. There are a number of things that they may need, actually. Now, medical history, diabetic, no autoimmune disease, no rheumatologic disease. I referred him for a medical evaluation with a rheumatologist. He never went. Now, interestingly, and I'm not going to torture people to try to figure out what is the underlying etiology, because it's not very simple. He was a bit of a cagey type of individual who mentioned something to me a couple of times. I sort of discounted it until I actually looked it up, and he had this procedure done called eye bright. And if anybody has ever heard of this, just put it into the chat room. I'd like to know if you ever come across this. This is a conjunctival plasty. It's designed to remove sun-damaged tissue. It is extremely invasive. It's invasive as heck. I mean, surgeon's going to remove conjunctiva, resect Tenon's capsule. They're going to apply mitomycin and maybe even Avastin. It was developed as an eye whitening procedure by a Beverly Hills ophthalmologist. I thought about putting the name down. I chose not to. He now calls it whiter eyes. So it's gone from eye bright to whiter eyes. There's also another procedure called cosmetic eye whitening. These are all trademarked. It is actually performed commercially in South Korea. Now, he kind of mentioned this very much in passing, didn't really think that it was pertinent, but during my evaluation and care of this patient, I actually looked it up and found that eye bright is a nasty procedure. The complication rate is 83%, and over half of the complications are considered severe. And the complications: conjunctival proliferation, scleral thinning with calcified plaques, which is what he had, ILP elevation, diplopia, hyperemic conjunctiva. It is a really ugly procedure. Another study looked at 4 patients who underwent a cosmetic procedure, and they developed necrotizing scleritis. It's very late onset. These things pop up 4 and 5 years later, and that's why you may not think to associate it with these procedures. The average time of this study was 51 months. They all had unilateral findings at that time. They were evaluated for autoimmune disease, rheumatologic disease, infectious disease, nothing. And because they're treating a very, very large area of mitomycin C, the necrotizing scleritis is going to be extensive and severe. And yet another study looked at 48 patients undergoing this procedure, 92% complication rate. Scleral thinning, calcified plaques, really just a really bad scleritis. And that's what had happened to this person. In the absence of anything else, he didn't go for evaluation. We concluded that this was from the whitening procedure. He ultimately ended up on oral steroids, topical steroids. One of our cataract surgeons did a cataract removal. He actually ended up doing very well. And my concern is at any time, I think his fellow eye can become involved. So nobody got in the chat room, so I think nobody else has heard about this, but there is something out there that people do this, very, very, very rarely, very few people, a medical or surgical eye whitening, and the complication rate is, exceeding 80%. So, Greg, I think we're about at our time. I'm going to start to wrap up. What a way to treat blepharotic red eye. Trouble starts about 3 years. The statute of limitation for malpractice claims is about 2 years. So with that, I think I'm going to turn this back over, and let's just land this and take everybody home so we're cognizant of everybody's evening.
Well, Joe, let me see if there's any questions here. Thanks for doing that. That was a great anterior segment, and it did match your title there, Corneas, Cases, and Complexities, anterior segment grand rounds. I don't see any other questions rolling in here. So thank you for doing that. And thanks for everyone for attending. That was anterior segment grand rounds, Corneas, Cases, and Complexities.